Welcome to this course on airway management, presented by myself, Dr. Nasser Hassan, an emergency medicine consultant and medical educator. In this video, we will follow my journey as I learn the core principles of airway management. Let's start by meeting the experts who will be guiding us. I am Dr. Nasser, your host. I am joined by Dr. Lila, who is an expert in airway management and will be sharing her knowledge with us. Now that you've met our team, let's begin the story. I recently received instructions from management to train our emergency department staff on airway management, and I need some guidance. I can certainly help you with that, Dr. Nasser, as I have completed advanced airway management training.
That is great news. Where do we begin with this training?
We should start with the fundamental definition of airway management. Airway management involves the procedures used to establish and protect a patent airway, ensuring proper oxygenation and ventilation while preventing serious complications.
To simplify this, we categorize these procedures into two types: basic airway management and advanced airway management.
Basic airway management techniques include head tilt chin lift, jaw thrust, use of oropharyngeal and nasopharyngeal airways, bag valve mask ventilation, and suctioning. Advanced airway management encompasses endotracheal intubation, supraglottic airways like the LMA, video laryngoscopy, surgical airways, and rapid sequence intubation. These are many options. How do we decide which to use? It sounds like we need a structured approach, like an airway management cycle. Exactly. The cycle consists of 4 distinct phases: assessment, preparation, execution, and rescue. The pre-procedure phase focuses on assessment to predict difficulty, and preparation, which involves setting up equipment, assigning roles, and having a backup plan. Moving on to the post-procedure phase, we have execution and rescue. Execution is when the plan is carried out, while the rescue phase serves as our backup if the airway proves difficult or the initial attempt fails. This is very helpful, but which phase do we start from? Where exactly does the cycle begin? That is the best part, Dr. Nasser. Because every airway is different, the cycle is designed to meet you exactly wherever you are starting from. I feel much more ready to manage an airway now, but I still need to know where to begin. What should my first step be? To get started, we rely on a structured approach known as the 7 Ps of rapid sequence intubation. The 7 Ps consist of preparation, pre-oxygenation, pre-treatment, paralysis with induction, positioning, placement with proof, and finally, post-intubation management. Let's begin with the first P, preparation. You must gather all necessary equipment, drugs, and confirm your team roles using a checklist like SOAP Me before you start. The second P is pre-oxygenation. Providing high-flow oxygen creates a critical oxygen reserve in the lungs, extending your safe apnea time during the intubation procedure. The third P is pre-treatment. We administer specific medications about 3 minutes before induction to minimize the patient's physiological response to laryngoscopy. Fourth is paralysis with induction. By pushing the induction agent followed immediately by the paralytic, we achieve the best possible conditions for the attempt. Fifth is positioning. Proper alignment, such as the sniffing position, is vital for a clear view of the vocal cords. Sixth is placement with proof. You must verify tube placement using waveform capnography, which is the gold standard for ensuring the tube is in the trachea. Finally, the 7th P is post-intubation management. This involves securing the tube, starting ventilator settings, and providing necessary sedation. Always keep in mind that a difficult airway cart should be fully prepared and accessible before you ever need it. Consider this case study. A patient with facial burns arrives with stridor. We must recognize the risk, call for help, and prepare our rescue plan immediately. Let's look at this scenario. A 55-year-old male arrives as a house fire victim with visible facial burns. He's anxious, but his voice is hoarse with audible stridor, and his oxygen saturation is 90%. What is your first priority here? Reassessing just 5 minutes later, his condition is deteriorating. The stridor is louder, he's struggling with accessory muscles, and his saturation has dropped to 84%. He is becoming drowsy. We must act now. Inhalation injury causes rapid, progressive airway edema. Delaying intubation risks a crash scenario where the airway may completely close. We must secure a definitive airway early, call for specialized backup, and have a surgical airway kit ready. Once the tube is in, we must confirm placement. Waveform capnography remains the gold standard. We also check for bilateral breath sounds, watch for symmetric chest rise, and follow up with a chest X-ray. You've successfully navigated the clinical reasoning for this critical case. I am confident in your ability to manage airways. Thank you for your support, Dr. Lila. To continue building your expertise, consider these recommended courses, ranging from emergency airway management to advanced trauma and cardiac life support training.